which is key because there are local changes and local policies that you need to be aware of. Some of the mitigating factors, we covered that earlier, and then diagnosis of brain death and ancillary tests. So why do we do this evaluation of death by neurologic criteria? Usually death meant cardiopulmonary death, but we know that with critical care coming on board, with respiratory failure being treated with mechanical ventilation, now that we can keep patients that progress to brain death on machines. So we needed to have some criteria in order to figure out when these patients actually met the definition of brain death. So the practice parameters, the key is knowing the Uniform Determination of Death Act that came out and was published in 1995, that you could either die from circulatory and respiratory function loss or irreversible cessation of the entire brain, including the brainstem. So how do we do this? This is the evidence-based guideline that's out there right now from the AAN, to be aware, from Neurology of 2010. So I refer you to this article if you're interested in looking at this more. So we're going to start with this question. In order to begin brain death testing, we had a similar question earlier this morning. You must have a systolic blood pressure less than 90 millimeters of mercury, a mechanism of brain injury that would result in brain death, C, a core temperature less than 36 degrees Celsius, D, never received neuromuscular blockading agents, and E, large volumes of dilute urine output consistent with diabetes insipidus. Okay, good. So you have to have a mechanism of brain injury that would result in brain death. Remember, you have to have a systolic blood pressure greater than 100 to start the exam. You have to have a core temperature greater than 36 degrees. You can have received neuromuscular blockading agent, but you need to check that that effect is gone. We'll talk about that in a minute. And then DI can be seen, but is not the criteria for brain death. So again, it's the irreversible loss of all the clinical function of the brain, including the brainstem. You have to have a mechanism. So you may see an image like this, and that tells you on CT scan that, yes, this patient may be brain dead. When patients come in with anoxic brain injury, you know, their scan, if they get one, is going to look normal. You don't have to repeat the scan to see this, which can, if you do repeat a scan, you'll typically see the loss of gray-white junction, which is consistent, but you can have the history of anoxic, enough downtime and anoxic brain injury that would make you believe that this patient is brain dead. So the mitigating factors, and we covered this a bit, but remember that if you have sedatives or drug intoxications in large enough doses that you would suspect that it interferes with your diagnosis, so enough benzos, opioids, the barbs, and tricyclic antidepressants, anticholinergics, anti-epileptic drugs, and then methanol. This cervical spine injury, remember we talked about that. You might, if the patient meets the criteria, you'll have to do an ancillary test, and then neuromuscular blockading agent we'll talk about in a minute. The body temperature we talked about. Metabolic derangement is really defined as what the clinician thinks is significant enough. So they talk about severe hypophosphatemia, for example, severe enough hyponatremia, and that's going to be up to you to decide. And then the systolic blood pressure. And I yellowed that there because the previous guidelines used to be the blood pressure only needed to be greater than 90. So if you're looking at old guidelines, that was what it used to be. It's now greater than 100. And the body temperature, you'll notice I made it yellow also because that used to be 33 degrees Celsius. That has changed to 36. And the hypoxemia is O2 sats, less than 85. So when you're looking at a patient who has had neuromuscular blockading agent, an easy way to see if that's gone is just to check deep tendon reflexes. If you're getting reflexes, that neuromuscular blockading agent is gone. If the patient, if you don't know, they don't have reflexes, you can do the train of 4 monitor. Some ERs have it. You can find it in the anesthesia where you put a twitch monitor on, putting it on the same median nerve, and you're going to see the hand twitching, and you can see on the slide, you'll see if there's no blockading, you should see 4 full twitches. If there's decrement, like the second one, you're going to see a twitch, and a little bit, and then nothing. Or if you see nothing at all, then that is somebody that's still blockaded. You may put it on the ulnar nerve, median nerve, sometimes the facial nerve, of course, is much more proximal. You want to see if that effect is gone. If there's any question, you need to wait and let that wear off. So we have to wait for the cessation of the entire brain. The next question is, the exam findings consistent with brain death include A, cough response, B, extensor posturing, C, triple flexion response, D, oculocephalic response or the doll's eye response, and E, a single breath at a PCO2 of 55. Which of these are consistent with brain? Okay, so what we're looking for when you're saying consistent with brain death is if they have it, that means that they would be still, if they have the response, they're not brain dead. So in this, a cough response means they still have a response, they're not brain dead. Extensor posturing means that there's still a bit of the brain, the upper motor neurons working, they're not brain dead. Having oculocephalic responses mean that 3, 6, and 8, some must still be working, so they're not brain dead. And a single breath means that they're still being able to respond in the medulla to that CO2 response, so they're not brain dead. The only one of these that's still consistent is the third one there, C, is a triple flexion response. So what is a triple flexion response? It's a response where if you pinch the toe, you'll see the ankle flex, the knee flex, the hip flex. So it's triple, it looks exactly, sorry, you might not see this, but you may see this where you're pinching and it comes up like this. And so that is a deep, it goes just to the spinal cord, it's the spinal cord reflex, and that can be consistent with brain death. The way you differentiate that between a withdrawal is you pinch the inner aspect of the leg, and if they're withdrawing, they'll pull away. Or if it is a triple flexion, it'll look exactly the same. If you pinch the outer side, if they're withdrawing, it'll move in. If it's a triple flexion, it'll again flex. That triple flexion response is a spinal cord reflex. And I warn patients' families, if they're at the bedside and they're watching, I say we may see a reflexive response, because otherwise they'll be going, oh, look, he's moving, he's moving. So it's important to prepare them and also be aware that you may see that response. So your examination, as we work our way down, I always start at the top, the mental status. Are you responsive or unresponsive? So they obviously should not be responding to you. You'll see their pupils may not be fully dilated, but they're going to be maybe mid-position, maybe a little bit bigger and unreactive. Then 3, 4, and 6 is the oculocephalic responses. So if they don't have trauma and you can move their neck, you're going to be moving their head. And of course, you're not going to want to see any response. Otherwise, you'll see that they'll have the doll's eyes where their eyes will stay in that position. If you can't do the doll's eye response, ice water calorics, head of the bed at 30 degrees. You put about 60 to 90 cc's of ice water in the ear after checking for an intact tympanic membrane. The response that if the brainstem's still working, you'll see the eyes slowly deviate to the cold ear and then move away, and then same on the other side. So if that's absent, then that patient still can meet the criteria for brain death. Then you move down into the next response of looking at corneal, so that's 5 and 7, where you take a cotton swab very lightly so you don't abrade the cornea, and just lightly swab it over the area, the cornea over the iris, not over the pupil. And then you look to see when you're doing painful response or suctioning them to see if there's grimacing to pain. And the suctioning also, you're looking for coughing. Any response is showing you that the patient is not brain dead. And then for motor response, again, you don't want to see a flexion or an extension, because that means the brainstem is still working. You should see nothing at all. If you're pinching the toe, you may see a triple flexion response, but be aware that that is a spinal reflex. So these funny reflexes that you can sometimes see have been described. The most common is some funny finger jerks, sometimes this undulating or some toe movement. I've seen sometimes finger movements they talk about in this slide about the Lazarus sign, where a patient sort of sits up. I've only seen that once, where there seemed to be a funny response, and that fatigued very quickly. Typically, these kind of responses might fatigue. If there's any question about what's going on, you really believe that that patient is brain dead by looking at their imaging and everything else, then you would want to do an ancillary blood flow study. So the respiratory part, when we get to the very bottom, we're also looking at apnea. And what we do with the apnea test is we pre-oxygenate the patient. And we're doing this, again, if your patient has a cervical spine injury, or you can't, sometimes your patient in trauma especially, we have patients where you can't see much of their eyes, You're not going to be putting water in their ears, and there's enough facial trauma that you may need to go to other tests. But the apnea tests you can do in those particular patients, and you pre-oxygenate the patient. You get their PCO2 normalized between 35 to 45. Then you disconnect the ventilator after also having a suction catheter. You tape the suction port, and you put about 6 liters per minute of oxygen on that. So you attach it to the ET tube, or place it down the ET tube. You don't want that more than 6 liters per minute, because you actually may ventilate the patient and wash out their CO2 if you have that flow too high. Then you undress the patient. Don't try and do an apnea test with the gown on. You need to look and see if the belly rises or if there's any chest movement at all, and you're watching carefully. The guidelines say to wait about 8 minutes and then draw a gas, and then if you haven't reached that CO2 of 60, you draw a gas every few minutes. We usually have 2 iStat monitors going at one time, because one's running and you're waiting for the result, and you're coming up on a couple minutes after that first one. You draw another one and then wait for that number of 60. If the patient, we talked about this, if they're hemodynamically unstable, then you want to draw a gas and then put them back on the ventilator. If they reach 60, obviously put them back on the ventilator, and then you'll declare that patient. So stopping the apnea test, and we covered that in the question. If they're breathing, you stop because they're not brain dead. If they significantly desaturate, and depending on the number for organ donor versus a non-organ donor, if you have cardiac arrhythmias or they're hypotensive, and we usually try to keep the systolic blood pressure higher, the 100 because of the organ donor potential, and then the PCO2 of greater than 60. In the guidelines, they do talk about that you could potentially put the patient back on the ventilator if the systolic blood pressure is dropping less than 90. But again, the PCO2 is 60 unless there are CO2 retainer. You want to go 20 above that. Now, the time of death used to be very arbitrary, so when you wrote it in the chart, but they've tried to, at the last guidelines, be very objective about it. So what you'll do is look at that iStat monitor, and the time that is actually recorded on that iStat is the time of death. It's not when you sign your note. It's that exact time. If it's an ancillary test, like a blood flow study, it's the time that's reported by the nuclear medicine doc when they read it, or if there's an angiogram, the time that angiogram is reported. So the ancillary tests, again, we are not required to do that, but it's when patients you're not able to do a full examination. The most common is the nuclear blood flow study, where you look for no parenchymal uptake. If you do it and they see flow, you can't repeat it a few hours later. You need to ask your nuclear medicine lab, but usually you have to wait 12 to 24 hours to repeat a nuclear blood flow. You may need to go to angiogram instead if you want to do it sooner. So cerebral angiogram. Some people ask about the CT angio. There's not enough literature right now, but it's a possibility that we might be able to use that in the future. There are other, and I mentioned this, using SSCPs, TCDs. We're not using EEGs anymore, and as I mentioned, it's not required in children. It used to be required in pediatrics, but the update that came out more recently now shows that, and most of you that are sitting here instead of the pediatric area, shows that in the pediatric, it is important to know that there's an observation period, that there are 2 apnea tests required in children, not in adults, but in children, and it can be done by the same examiner, but it's done at that different observation period. If the kids are older, then also 2 examinations with the 2 separate apnea tests, which is different than adults. So just having said that, the difference between adult and pediatric determination of death after neurologic criteria include the requirement for EEG, a lack of brainstem reflexes, a mechanism of injury that can result in brain death, the temperature, or 2 separate apnea tests. Okay, well, some of you were awake and some of you were not. So the EEG is no longer required anymore for the kids. It is that you need to do 2 separate apnea tests. The reason why EEG became a problem is it's not always available in different areas. You have to have a certain way that you do them, the montage, and it just became too complicated, but EEG is no longer required. So this is your nuclear blood flow test in someone who's alive, who has nice flow inside their brain, and this is someone who is brain dead. So the scalp has flow, but you don't see any flow inside the skull. Same here on the sagittal cut, nothing going on inside. So the options when the patient's dead, they will be removed from the machine, and that's the important thing to tell the family. And we usually go through the discussion of what happened to the patient, show them the imaging to the family, and then explain. And this is the key part where I think a lot of complications occurs when the family doesn't understand what exactly happened. We tell them that they meet the criteria for death. It is brain death. They look still alive because they're still on a machine, but they're looking at the shell of their loved one. So they're looking at the body of their loved one. And we will, by law, have to take a dead body off a machine. And I think that's important to explain to them. We don't say the words organ donation. So our job is that we pronounce death. And then if you're in a state where, and there's 10 states in the union that require 2 examiners, most do not. So if you're on that list there, you need to have a second examiner. So you find that second physician, that's what you need to do. And you're not going to discuss the word organ donation because by the conditions of participation with CMS, we're not allowed to say anything because you have to be an OPO designated requester in order to say anything. So what we do is we tell them that their loved one has died, that we're looking at their shell, that we're going to let them spend some time with their loved one, and someone else is going to come talk to them about what the next steps are, about how they can, the body is going to be removed from the machine. It's not a choice. You don't ask them for permission. You tell them it's going to happen. You give them time with their loved one, and the difference between the time is because they've shown in studies that by increasing the time that the family has to digest this and the time that someone who's trained to come in and sees them increases organ donation. This is what the IOM has asked us to do and the CMS is requiring us to do now. So except for the supportive donors, all therapeutic modalities have to be discontinued. They do not require consent, so it's important to tell the family it's not really a choice. We have to take your loved one's dead, we have to take their body off the machine. Someone's going to come talk to you in a little bit about this. And we leave it at that, have the OPO come and talk to them. If you're a designated requester because you've been trained, then you can give this discussion.